Welcome to the Nursing Home Strategies to Reduce Avoidable Hospitalizations Part 3 conference call. My name is Sylvia and I'll be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. During the question-and-answer session, if you have a question, please press star then 1 on your touch-tone phone. I will now turn the call over to Kristine Rogers. Kristine, you may begin.
Sure, thank you very much. And hello, everyone. This is Kristine Rogers with Lake Superior Quality Innovation Network, or Lake Superior QUIN. Lake Superior QUIN represents Minnesota, Michigan, and Wisconsin under the Centers for Medicare and Medicaid Services Quality Improvement Organization program. I would like to welcome you to this educational session entitled Nursing Home Strategies to Reduce Avoidable Hospitalizations, Part 3. All lines will be muted during this webinar. However, after the presentation, we will have a time for questions and answers, so please make a note of any questions that may come up as you listen, or place your question in chat, and we will address it. This is the fifth and final webinar in a series intended to support nursing homes participating in the National Nursing Home Quality Care Collaborative's efforts to improve resident outcomes and reduce hospital readmissions. The first webinar in this series, entitled Reducing Hospital Admissions to Improve Resident Outcomes, Quality, and Financial Incentives. Hopefully, you've all had the opportunity to view this 24-minute webinar, which provides the context for these learning sessions. On August 24th, we presented the second webinar in this series entitled Using QAPI to Reduce Readmissions. During that session, a change of condition process evaluation tool was introduced, and nursing home teams are encouraged to complete this tool to identify process changes that your home may need to focus on to improve communication about a resident's change in condition, which in turn would help reduce hospitalizations. On August 30th and September 11th, we presented the first and second webinars that shared strategies that nursing homes are using to reduce hospitalizations. All four of the previous webinars are recorded, and a link to the webinar recordings and handouts will be shared at the end of this presentation. In this webinar, we have the privilege of hearing from 4 nursing homes who will be sharing strategies they have implemented to reduce hospital readmissions and improve care for residents. As a reminder, the National Nursing Home Quality Care Collaborative uses this change package as a reference to great ideas and practices from high-performing nursing homes across the nation that have created interventions and maintained positive outcomes for residents and staff. Included in the change package are strategies that these high-performing nursing homes have used to prevent avoidable hospitalizations. You will note that in Strategy 6, provide exceptional, compassionate clinical care that treats the whole person. There are action items specific to the transition of care between shifts, departments, and all care settings. Please use this link to access the change package. Now, our first speaker is Dawn Hummel from Bethany Retirement Living. Please note that we needed to change the orders of the speakers, so if you're looking at slides and you have those in front of you, please move ahead to slide 37, and then we'll go back to the original order. So, Dawn, would you like to share with us what you've done at Bethany Retirement Living?
Absolutely. Thanks for asking me to be a part of this this webinar. So, just a little bit about who we are. Bethany Retirement Living, we have 2 campuses, 172 beds and 116 beds at the opposite campus. I'm the senior executive of our skilled operations, and I go between the 2 campuses. So what we did to start off with, and this is some of the earliest collaboratives, thank you, this is the perfect slide. So we talked a little bit about what can we do to impact rehospitalizations and really look at avoiding some of the people that are transferring back and forth. And the easiest way to describe it is we started off by saying we need to work on building relationships with these families, residents, and patients. We have 2 active TCUs. And really the focus initially was for us just to get in there and start having conversations early and often. And we do that in a variety of ways. We try to get a care conference set up immediately when we've got a new admission. And where our goal is within the first 10 days to have that initial care conference. At that time, we talk about advanced care planning. We talk about the risks that are associated with going back and forth to the hospital. And I think some of the education that we've done, not only with families and residents, but has been with our staff is on the slide that you're looking at. We talk about the stress involved with transportation. We live in North Dakota, so, 30 below wind chill, on a stretcher, not fun to have to get transported back and forth. We talk about the doctors and nurses who do not know you, and I think that's, again, the focus that we have about the relationships that we work on building with the resident and their family here in the facility. They get to know the rounding providers. They get to know our nurses, and I think that's a key piece in helping them feel comfortable and why they choose to stay in the facility versus being hospitalized. And of course, we talk about the standard things that you all know. You have a greater risk for skin breakdown if you're hospitalized, pressure ulcers, all sorts of different skin issues. You're obviously exposed to more infectious disease processes, and again, there's a risk of you falling in an unfamiliar place. I didn't include in there as well deliriums that are frequent with people that go back and forth to the hospital. We look at our residents that have cognition issues, and the hospital is just not a good place for them to be oftentimes if we can treat them in the facility. Next slide. This just talks again. This is just a slide that shows really all the people that go into communities, and really just the whole system that goes into it. Next slide. That's not it. That's not my slide. I'm missing the slide on the Interact tool. There we go. So one of the things that we've used Interact really for almost 7 years. We've used the Interact platform, and that's one of the things that we look at. So we talk about avoidable hospitalizations, and oftentimes we'll go through some of these things with families. We use the stop and watch tools. We look at early symptom recognition, and really the biggest thing that we look at is explaining to the hospital, the on-call physicians, the emergency room, what our capabilities are within the organization. And I think sometimes that's education to families as well. They think that going to the hospital is going to fix whatever happens to be ailing them, but at the end of the day, having those conversations about what we can do in the facility is one of the biggest things that's helped us to keep people in the facility. We also talk to families and are very, very pointed in the conversation. Do you want to go to the hospital, or would you prefer to be treated in the facility? If they decide that they want to stay in the facility and be treated, we denote that on the front of the medical record. There's a bright pink card template that talks about please review their last advanced care planning notes. This person does not wish to be hospitalized, and please honor their wishes. I'm not using the exact verbiage, but that's been helpful too, because it alerts the nurses immediately when they're talking to the providers to say this person does not want to go back to the hospital, and then we'll look at a different approach. As far as the advanced care planning that we do, we audit that regularly, and I think that holds our teams accountable to make sure that we've got health directives, that we've got all of that information, advanced directives in our record, and then we share that back and forth with the hospitals and really try to do a good job. I think we're at about 82, 83% of our residents have those in their records, and I think that's a helpful piece as well. And then again, auditing it. The next slide. I want to see if we're a little bit out of sequence. Yeah, we talked about this. Next slide. We talked about that. We talked about that one. Yeah, and then this is what I was just talking about with the pink card that goes on the front of the medical record. And our nurses really like that. Next slide. One of the things that we work on as well, and I alluded to this a little bit, is continually discussing with the physicians, especially those on call, what our capabilities are, and that's ongoing education. Most of the time, our on-call providers that are taking the phone calls in the middle of the night do not round in the skilled nursing setting, so it's an education piece for all of them, and that's ongoing. Next slide. I think at the end of the day, the key piece for all of us at Bethany, and we've this is all of our earlier interventions, is just really talking to all people, communication with all parties. And I think at the end of the day, when we do that well, especially with the residents, their families, and our staff, we really are in sync with what the resident wants to do, and we see a decrease in people transferring back and forth to the hospital. And that's really what our focus has been, is communication, and then again building relationships with the residents and families so that we really are their go-to people and they feel comfortable staying in the facility. Obviously there's people that are going to need to transfer back and forth, but by and large we've really been able to decrease a lot of the people that previously would go back and forth. I think that's it for me.
Thank you very much, Dawn, for sharing your team's work with us.
Absolutely.
Yeah. If you have any questions for Dawn, please put them in chat. And the next nursing home that we will be hearing from is Lyngblomsten Care Center. I will now turn it over to Greg Wainman and Kristine Rogers to share the work they are doing to prevent avoidable hospitalization.
Thank you, Christy. This is Kristine Rogers at Lyngblomsten, and I'm just going to talk a little bit about our care center. We were organized in 1906 by 11 Norwegian women who wished to provide a safe home for the elderly. We now have 3 buildings on our grounds, the care center, and 2 independent apartments. We are nonprofit, faith-based. We're overseen by 27 partnering congregations. Lyngblomsten is located right in St. Paul, and we're nestled in between the Minnesota State Fair and Hummel Park. We are a 225-bed facility, 195 skilled beds, and 30 short-term rehab. We chose this improvement project because we felt that many of our hospital transfers were not only necessary, but then our residents were coming back in seemingly worse shape than when we sent them to the hospital. We believe that we could provide a lot of the same things that they had in the hospital right here in a more holistic manner. Next slide. We felt that there were numerous reasons that were causing these unnecessary hospitalizations. We felt that there was a lack of our staff, providers, residents, resident representatives, understanding of the services that we could actually provide right here at Lyngblomsten. We also felt that there was a lack of our staff knowledge in completing thorough assessments when our residents did have change in conditions and good, accurate SBAR charting. But one of the key things that we felt significant was the lack of our staff's confidence in clearly communicating a change in condition to the provider or the resident representative. We noticed that next slide, many of our residents on return from the hospital appeared to be in worse shape than when they left the facility. We felt that there were many risks in sending our residents to the hospital, such as skin breakdown, infection, falls, delirium, insomnia. Now I will turn it over to Greg, our Director of Nursing at Lyngblomsten.
Thank you. Next slide. So our goals, what were our goals? Our goals were to prevent as many unnecessary transfers to the hospital as we could. And this was really in keeping with the change package item number 6 that we introduced at the beginning. It was beyond just the CMS requirements, which we know we all have, but really we felt like doing so was really the best thing for the individual. And so we felt like we could provide better care, keep them in a familiar environment, avoid any of those potential problems that can happen at the hospital, and then any of those complications that can occur during that transfer of care that we know is always a possibility. Next slide. So we started almost 2 years ago, before the rehospitalization rates were publicly being reported, and so we used the tools within our electronic medical record. We used point-click care here, and calculated our 30-day readmission rate and kind of worked from there as our internal benchmark. Next slide. So some of the things we did initially were create a resource guide for our staff on what to assess in a change of condition, what needs to be reported immediately and what can wait, weight triage tool, guidance on what to assess depending on what conditions were presenting from the individual, the different care pathways, and those things are things we probably all are familiar with through the Interact program and through some AMDA guide tools. But what we really did specific and we felt was important for us was a facilities capabilities tool for our staff that not only included what we're capable of doing, but those timelines in which we can do those things, whether it's starting an IV within 4 hours or getting a medication within 15 minutes or what have you, so that we can communicate that and best collaborate with that provider if we're trying to strategize on a plan of care that might prevent that person from going to the hospital. And the other thing that we did, because we knew that communicating to the provider in a clear, confident manner was so important, we actually worked on scripting with our staff on how to present in a cohesive way a change of condition to a provider so that they would have confidence that you knew what you were saying and doing and that they'd be more likely to keep that person at the facility with you. Next slide. So these are just a couple screenshots of the tools I was just referencing. So that and the Know It All Before You Call tool was something that we made electronic and put into our intranet here so that our staff could have immediate access to that and could search it very quickly and find a given condition. And on the right is kind of a script that just talks about the different components that should be included in your conversation with the provider and how that should flow so that it comes across clearly to the provider. I once had a medical director share with me that he said, you have 20 seconds to capture my attention and make me believe that you know what you're talking about. So we felt like really having that tool together was important for our staff to be able to do that successfully. So how did we implement these changes? Well, we first started out by communicating with our providers. We had a luncheon. We invited them to discuss our goals of what we were trying to accomplish with reducing unnecessary hospitalizations. And we talked about the facility resource tool that we were developing, and we spoke at length about our facility capabilities so that they really clearly understood what those things were. So they knew what we could do with them while the individual stayed at our facility. We also introduced the idea to our families at one of our biannual family nights. And at that meeting, we spoke not only about what our goals were and what we were trying to accomplish and what we could do here, but also those risks associated with going to the hospital, and so that they had a better framework to make decisions about what to do for their loved one when they're, called in the middle of the night about a change of condition. And that was very important, and that was a very fruitful meeting. And then probably the key to our success, at least what we feel has been the most ongoing success, is our weekly Interact meetings. That's what we call them, where we review all of our hospitalizations. Next slide. At those meetings, we use the Interact Quality Improvement Tool, and they happen once a week, and our medical director is present along with nursing admin, and then we invite all of our nurses, and particularly the nurses that were involved in the transfer, if possible, the provider group that might have been associated with that individual, if they're available and can come. And we felt it was so important that we incentivized it by not only paying the staff when they come in, but also giving them a $25 bonus to attend the meetings. So a week before, an email goes out and announces who we're going to be reviewing. It lists who the provider is, who the nurses were that were on duty that sent the individual in, and what were the kind of basic review of the conditions that were changing that caused them to be sent to the hospital. That way we can prepare. The clinical managers for that individual are asked to complete the quality improvement tool before the meeting so that they can come to the meeting and present the information. And then that is conducted in a case review fashion. Next slide. Our medical director asked that the information be presented. For instance, like, 84-year-old female with a diagnosis of COPD presented at 8 o'clock on Thursday with shortness of breath and so on and so forth. It goes through those pertinent findings, the assessments that were completed, also what information was provided to the provider, the on-call, or the family, and how those conversations went, all to help determine whether we felt like that hospitalization was the right thing to do or not. So that's been very, very fruitful to learn. And when we get what we call learnings that come out of those meetings, we put that information together and get it to our staff, particularly those that weren't able to attend the meetings, obviously. So it goes out in our newsletters or postings around the building. One of the things that kind of has grown from those meetings that we feel has really been important is our medical director, being a teaching physician, really enjoys taking time to discuss conditions that maybe were a part of the transfer. Maybe he expands beyond what was happening in that given situation and discusses those things. And that helps the overall fund of knowledge of our nurses grow, which again builds that confidence and allows them to communicate with another provider in a way that they feel more comfortable with. Next slide. So you talked about this, and we'll move on. Next slide, please. So lessons learned. So really some of the things that we found was really the most simple physical assessments are often overlooked by staff. They do vital signs and they take subjective complaints and they ask what the individual or family might want to do, and we don't put our hands on people, at least not enough according to our medical director. So we've worked a lot on that. We feel like that's really been important. Communicating the availability of particular diagnostic testing to an on-call provider, for instance, and what we can do and how quickly we can do it has been very important. Also, that same communication to families about what we're capable of doing here. For instance, the different types of care we can provide, and so on and so forth, so that they can feel more confident about keeping their loved one here. Working with providers in a way that's not just about whether they should go to the hospital or not go to the hospital, but maybe it's maybe they should go to the hospital, but let's try these things first, and let's evaluate this, and then in 2 hours call me back, or call me back if this changes. And developing a strategy, that's really been important for us, I think, to work on with our staff, and that's been very successful. Next slide. This whole process has been an ongoing quality improvement project. While we've been working on reducing hospitalizations, we've been evaluating which hospitalizations have occurred and making adjustments. One of the things that has come up more recently is that we have people going out to clinic appointments and dialysis and things that are being sent to the hospital to be treated for things that we could have easily taken care of here at the facility. So we have to look beyond our families and our providers and letting others know what our capabilities are and look to our partnering providers, whether that be a specialist or a dialysis clinic. So what we developed was a letter that goes out signed by the medical director, myself, that says, if you have a change of condition that you're seeing in this individual, please contact us so we can partner together and collaborate on a potential intervention that might prevent them from going to the hospital unnecessarily. We've yet to see if that's going to bear any fruit because we've just begun it, but it's just part of this, what's come out of our interact meetings and what we're seeing when we see people being sent to the hospital. Next slide. So just in summary, we created a nursing resource guide, which was very important. We provided education about what was in there and our capabilities. We spoke with our providers and our family members. But by far, our weekly meetings have really shown us the things that are happening, and we've been adjusting things according to those meetings there. So while our rehospitalization rates really haven't changed much in the last couple of years, we do believe that we have seen an increased acuity at our facility, and keeping our hospitalization rates stable to us is a success because we really feel like we've been able to keep people here that we otherwise might not have in the past. And we think that we're giving, better care as a result of it. And then last slides are just the resource tools that I referenced during the presentation. That's it. Thanks.
Thank you very much, Greg and Kristine, for sharing these great ideas. We really appreciate it. Again, some of you might have questions for Greg and Kristine, so if so, put them in chat now, or at the end you can enter into the form queue, and we'll address those questions at that time. Our next speaker is Lola Evans, and she's from Advantage Living Center. Lola?
Yes, thank you for having us. Advantage Living Center, we're located in Redford. We are a 5-star faith-based organization. We're an 88-bed facility that encompasses 44 long-term patients, 24 short-term, and 20 in our greenhouse project. So let's go ahead and talk value-based purchasing. As we know, in 2014, Medicare decided that if you go ahead and do a good job, you'll get paid for it, okay? So all of our high performers, there's an incentive pool, and if we can go ahead and keep our numbers up, we'll get those incentives. Go ahead to the next slide for me. We also understand if they did it, then they take it away. CMS announced that there will be penalties imposed for our preventable and potentially avoidable 30-day readmissions. Those are patients that have diagnosis of heart attack, heart failure, pneumonia, COPD, and joint replacement complications. That's why it's extremely important to get cardiology services involved. Get your respiratory therapist involved. And for those joint complications, in order to avoid them, be diligent with making those ortho follow-up appointments. Next slide. What are some of the contributing factors to the patient going back out of the facility to the hospital? We found that within 8 days, they're generally back in the hospital related to the original condition, and normally closer to 30 days after discharge, it's due to lack of follow-up care, or they develop new illness or complications. However, patients that are discharged from the hospital to the SNF between 8 a.m. and 1 p.m. are less likely to be readmitted to the hospital. I can say that some of the factors in that is because you have a physician in-house, you're able to get the medications from the pharmacy in a timely manner, in which you're able to better control their pain. Next slide, please. Other factors that contribute to your patients going out can be gender, age, income. They're all good predictors of a 30-day readmission to the acute care facility. A good way to determine if your patient is going to go out is to get to know that patient. Understand that patient in its entirety. The best way to do that is to get the IDT team involved. Have your goal planning for success. Meet with that patient, meet with that family within the first 72 hours. Determine any barriers that could be for them going home or any barriers that could get them sent back out of your facility. Next slide. The risks that are at greatest, the populations at greatest risk for readmission are those that are lack of family support, are limited English-speaking patients, and those with a limited education and knowledge base of their actual diagnosis. So if you have those good educators, if you have a great dietitian, make sure they're getting in, they're talking to those new diabetics. Make sure your physicians are talking to them about those critical illnesses of CHF and COPD. Next slide. What can your facility do to reduce hospital readmissions? Next slide. Advantage Living Center has developed a game plan. So our game plan, next slide, is that within the first 24 hours is extremely crucial for that patient. We make sure that our unit managers are extremely involved. They meet with the patient and hopefully the families within the first 24 hours to help orientate them to the facility. This will decrease the anxiety of the patient and the family knowing, and they completely understand that they have a point person to talk to. Ensure that the patient is evaluated by the physician. Sometimes this can't happen in the first 24 hours if your patient comes in over the weekend, but make sure they're seen within the first 72 hours. The admission nurse should begin the sepsis screening process, and they should continue for 7 days post-admit. This will address any concerns immediately with the mid-level provider. Equally important is that you review baseline vitals. You want to be looking for those variations. Did the temperature go up a little bit? Is the heart rate elevated? Those key indicators can prevent that patient from becoming septic and going back out of the door. We require that our nursing staff here at Redford complete walking rounds. And now this is something different than the grand rounds that's done with the physician. This is the daily walking rounds at the beginning of their shift. It's an excellent opportunity to share information between shifts, make observations, as well as get feedback from the patient. And always make sure you review the medications with the patient and the family upon admit to your facility. Next slide. Again, our unit managers are complete game changers. They come in the morning before morning meeting. We ensure that they review all of the progress notes, the 24-hour report, as well as review any orders that was placed by the physician. Also, we decided to make sure that we are looking at those advance directives at that time. If they're not filled out, we're working with social work to make sure that we get those things in as soon as possible. We want to make sure we understand our patient's wishes. If they don't wish to go back out to the hospital, we don't want to send them out because we didn't get the paperwork done in a timely manner. We also include small group huddles where we talk to our CNAs and we talk to our nurses, and we make sure that we communicate effectively information. A lot of times the CNAs are the first person that knows that that patient is going bad. So involve your CNAs in your huddle. Next slide. It's grand rounds time. Grand rounds is completed with the interdisciplinary team. That should include your physician or your mid-level as your nurse practitioner or your PA. You want to get physical therapy, occupational therapy involved, the dietitian, your social worker, and someone from your nursing department. It doesn't necessarily have to be the unit manager. It actually works a lot better if sometimes you involve the actual staff nurse. So she knows that patient. She's there every day with that patient. And she can tell you a little bit more that you won't find just from the nursing manager. During that time, it's great if you have family that's there when you're doing grand rounds, because that's a good time for the physician to have those conversations regarding critical illness with the family, and suggest any type of palliative services that may be available to them. Next slide. Discharge planning. We all understand that discharge planning begins the moment that the patient is admitted to our facility. We should also include weekly team meetings to discuss transition to care. That's also known as your Medicare meeting. You want to ensure that the social worker as well as physical therapy are ordering the essential durable medical equipment that will be required for the home setting, like the bedside commode, hospital bed, shower chairs, walker, and oxygen. And ensure that the social worker is making a 7-day follow-up appointment with the primary care physician and providing a complete listing of the medication to the doctor as well. After discharge, within 72 hours, you want to contact the family and or the patient so that you can address any concerns that sometimes will go ahead and warrant them going back to the hospital. But if you let them know, inform that patient that they're able to return to the facility if they feel they're not progressing at home to get a little bit stronger. Next slide. And very last but not least, one of the most important things is to become part of a prevention collaborative. This will help your facility to understand why patients are readmitted and identify best practices to reduce the readmission rate. Thank you.
Thank you, Lola. Great work. And again, if you have any questions for Lola, please put them in chat and we'll address them after our next speaker. So our last speaker this afternoon is Kerry Regentin from Autumnwood of Deckerville. Kerry? Carrie, if you're muted, you need to unmute your phone. It would be *6.
I'm sorry, did you say Terry?
Carrie.
Terry. Okay, never mind. Goodbye. I'm muting.
No, Carrie, you're up. Autumnwood of Deckerville, your turn. So, Carrie, are you able on the line, and are you able to unmute your phone? Carrie, did you hear that? You could press *0.
Okay.
Is this Carrie?
Yeah.
Okay, your turn.
Sorry about that.
That's okay.
And my name is Kerry Regentin, and I am the administrator at Autumnwood of Deckerville. We are a much smaller facility than some of the other facilities that have talked today. We are 84 beds, duly certified. We are a 5-star facility, and we are a member of the Sienna Healthcare community. We did identify a problem with our 30-day readmission rate back in 2016. But as you can see, our readmission rate at that time was creeping up to about 40%. And that seems very high, but in a facility our size, we are predominantly made up of a long-term community. So probably only about 10 to 15% of our population at any given time is skilled and in that 30-day window. So 1 to 2 residents being discharged in that window can make a big difference in our percentage. When we decided to tackle this problem, one of the biggest things that we identified as an interdisciplinary group was that we needed to have better physician involvement and also staff education. And we're going to talk a little bit more about the staff education and what we identified in a later slide. This information was identified in basically a general questionnaire that we had given to the nurses. We asked for their input, for their ideas, and for any problems that they felt they had in either getting a physician to keep a patient in-house or if they felt that there was a lack of understanding of our clinical capabilities. Next slide. So our goal. At that time, because our rate was high, we wanted to set a goal that we felt was attainable. So at that point, we set to reduce our 30-day readmission to less than 20%. Obviously, one of our big goals was to re-educate the staff. And as we kind of found out, we can have all the tools in the world, but what's needed is the knowledge of how to use them, why to use them, and when to use them. We do utilize the eInteract system here in our facility. The girls would complete change of condition forms, XBARs, and, you know, at that point when we got the information back from our nurses on the questionnaire, a lot of them felt that these tools were just extra paperwork, that they served no purpose. They just felt like a lot of it was duplicate, and they just really didn't understand why it needed to be completed. Physician involvement, I kind of bolded that. We also found that a lot of times the physicians felt that their easiest course of action was to just send someone to the ER to be evaluated by another physician. They felt that they were just getting kind of facts presented from our nurses, but not always getting a clear picture of what was going on with the resident or the history needed for them to make a really good decision on what they wanted to do for treatment. Next slide. Re-education. We wanted to find a way in our facility to really engage our nurses. We found out that they were kind of burned out on the memos and the
all staff meetings where you're covering multiple topics at one time. A lot of times the girls were staying after shifts to do this training and they just weren't engaged. So we came up with an idea as a group for what we call the Lunch and Learn. So we set up an off-site training at a local restaurant, had a lunch served, and focused on one topic. So this is something that we do quarterly for our nurses, and we found that the nurses really enjoyed this. We had a speaker come in specifically on 30-day readmission and just basically kind of explain to them what it was. I was really amazed because we talk about 30-day readmissions all the time, but how many of our nurses really didn't understand what that meant or how it would affect the building. So we found that the biggest key that we could do as a facility is making sure that our key people that are taking care of these residents understand how critical it is to keep our readmission rate at a lower level. We did do some quick guide references after we did our re-education, and just like little pamphlets that they can keep right at their fingertips for quick reference and, basically things that they need to look out for. The assistant director of nursing here has a little cheat sheet, is what we call it, that she circulates on a daily basis for our nurses. And basically, it identifies everybody that's still in their 30-day window. On this little handout, it basically gives the patient's diagnosis, things that they need to look out for, if there was any kind of recent changes, or if anyone has completed any kind of change for them in the last 24 hours. So this is kind of a good tool for them, so they basically know where their patients are when they start their shifts. And they have specific things identified that they need to look for. The re-education of the SBAR, staff, watch, and e-interact, that was another thing that basically, when we went through that with the nurses, we kind of explained to them that it's not duplicate charting. It's very important to make sure that we're doing this. And obviously, we kind of let them know that if you're completing your SBAR and completing these different tools, that serves as your progress note. So we tried to kind of explain to them that it can not only be used as the progress note, but also as a tool when they're calling the physician. Next slide. Successes. So we talked a little bit about the Lunch and Learn. That was definitely a huge success for us. We got a lot of really positive feedback from the nurses, and we found that going to a more focused meeting, especially on those really important topics, was very successful for us as a group here. We noticed an immediate drop in our readmission rate. We had went from 40% and dropped to about 15% in the following quarter, and then around 10% or less for the remainder of months. What worked? Re-education, and I really want to stress that I know we talk and we go to a lot of different seminars as administrators and directors of nursing, but I think the key is finding how to educate your staff. Every building's different, and I know that we all have different ways of communicating information, but I think you have to find a way to really engage the staff to make sure that you're getting the information across in a way that they can relate to. Physician involvement, that was also something that was successful for us. We actually reached out with our physicians. We did talk with them a lot about the e-interact and basically kind of got their feedback as to what they're looking for when the nurses call them. So that's also something that we worked on with the nursing staff. We also reached out to our local hospital. We partnered with them to help to kind of continue reducing our readmission rate. And we were actually very fortunate to be able to have some of the ER physicians that work locally come and become credentialed here at our facility. So that's been a very positive thing for our buildings because it does help them understand our challenges, but also understand our clinical capabilities. Next slide. What didn't work? The main thing that didn't work was flooding them with tools. As I talked about a little bit earlier, you can give them all the tools in the world, but if they don't understand the importance of the topic that they're using them for, or don't understand what they are, they're not going to be beneficial. Completing tips with no real engagement from staff. That's another thing that we found. You can create a lot of performance improvement plans, but if you're not getting engagement from your staff or input from your staff, they're most likely not going to be successful. Another thing that didn't work was making assumptions that your staff truly understand, what a 30-day readmission means. And I think that was something that prior to us really tackling this problem, we didn't understand as an interdisciplinary team. Next slide. So this is kind of our progress to date, so you can kind of see where we are. We do have trends where they spike up on a certain month, but for the most part, we have been pretty stable in keeping our readmission rate well below our goal. Next slide. And what we learned. Yes, we did meet our goal that we set out to. As I said, the right kind of training is definitely instrumental. Getting your physicians to buy in and become more involved is definitely key, and getting your staff to buy in. Next slide.
Thank you, Carrie. And thanks to all the speakers for sharing with us today. So we now have time for questions or comments for the speakers. Operator, can you remind our participants how to get in phone queue for questions or comments?
If you have a question, please press star, then 1 on your touch-tone phone. Once again, if you have a question, please press star, then 1.
Thank you. Or you could also put your question in chat if you would prefer. I just have a question for Carrie. The lunch and learns, it sounds like those are very successful, and we're just wondering, were those just for the nursing staff, or did that include the CNAs, or who did you invite to those meetings?
Can you hear me?
Yes.
Okay. Actually, for the first one that we held, we did that just for the nursing staff because the first thing that we wanted to do was do some re-education on our e-interact tools. We found that we were having a really low compliance rate with people completing those, so we really wanted to see why it was that they weren't getting, completed, and then obviously making sure that people really understood the importance. So we do them with CNAs on specific topics as well, but the one for the 30-day readmission was specifically for nurses.
Okay, thank you.
Yep.
No questions on audio.
Okay. So let's look at this next slide here, and you'll see that thanks again to everyone, Dawn, Greg, Kristine, Lola, and Carrie. We really appreciate all the great information you shared. And on this slide, you'll see a link to the information about the recordings of the webinars that were part of this series. So if you, there's that link you can go to, and you can find information on all of our past webinars. Okay. We do appreciate all of your efforts to improve the quality of care and the quality of life of those living and receiving services in all of your nursing homes. And if you have questions about this webinar or about the National Nursing Home Quality Care Collaborative, please refer to this slide for the contact information for the leads from your state. As you exit from this webinar, a window will open to a short evaluation. We've also included a link to the evaluation in the chat box. We're doing that right now. So please take a minute to provide feedback on today's session. And once you've completed that evaluation, you'll receive a certificate of participation. You're also able on that evaluation to, if you're interested in other educational events that you would like to see us host, please also include that in that evaluation. Okay, this concludes the webinar. Just a reminder that this session was recorded and will be available on the Lake Superior Quinn YouTube channel in a week or two. And thank you all very much for participating, and thank you again for all of the great speakers. You have a great afternoon.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.